Welcome to Studious, and to one of the most elegant topics in all of histology. Today, we are going inside the body's most fundamental covering tissue, simple epithelium. This is a visual atlas, a structured, image-driven journey through cellular classification, biological function, and clinical pathology. Before we dive in, ask yourself this question. What does your lung alveolus, the lining of your blood vessels, and the tubules of your kidney all have in common? The answer? A single, beautifully thin sheet of specialized cells, just one cell layer thick. And yet, that single layer can exchange gases, filter blood, secrete hormones, and even when things go wrong, give rise to cancer. This is not just a memorization exercise. Understanding simple epithelium is understanding the logic of how your body is designed. Form always follows function, and in histology, the shape of a cell tells you exactly what that cell is built to do. So settle in. We are going to systematically decode every type of simple epithelium, from its microscopic architecture to the precise body locations where you will find each one, to the real clinical conditions that arise when things go wrong. Whether you are preparing for your first-year histology practical, studying for USMLE Step 1, or simply fascinated by the micro-world inside you, this video was made for you. Let's begin.
Let's start with the big picture, because simple epithelium does not exist in isolation. It belongs to one of the 4 fundamental tissue types that make up the entire human body. Those 4 tissue types are epithelial, connective, muscle, and nerve. Each has a distinct purpose. Connective tissue provides structural scaffolding and support beneath the surface. Muscle tissue generates kinetic force and drives movement. Nerve tissue transmits electrical signals at extraordinary speed throughout the body. And epithelial tissue, our focus today, is the body's primary covering and lining material, found on surfaces both inside and outside the body. Think about that for a moment. Every external surface you can see, your skin, is epithelium. Every internal surface you cannot see, your gut lining, your blood vessel walls, your kidney tubules, your lung air sacs, is also epithelium. This tissue is literally everywhere. Now, here is the key defining feature of all epithelial tissue. It is avascular, meaning it has no direct blood supply of its own. It receives its nutrients by diffusion from the connective tissue lying just beneath it. Epithelial tissue also acts as the body's gatekeeper, controlling what passes in and out. It protects against mechanical damage, infection, and fluid loss, while simultaneously enabling selective absorption, secretion, and exchange. In short, epithelium is the body's interface with the world.
Now that we understand what epithelium is, let's examine its architectural blueprint, how it is physically organized, and how it connects to the rest of the body. Every epithelial tissue has the same fundamental structure. At the top is the apical surface, the so-called free edge that faces outward, either toward a body cavity, a hollow organ lumen, or the external environment. This is the functionally active face of the cell. At the bottom, anchoring the whole structure, is the basement membrane, also called the basal lamina. This is a specialized extracellular matrix, a thin but incredibly important sheet made primarily of collagen type 4 and laminin. The basement membrane is not just a passive anchor. It regulates cell polarity, controls the diffusion of molecules, and plays a vital role in tissue repair and regeneration. When epithelial cells become cancerous, one of the earliest and most critical events is their invasion through the basement membrane, a marker clinicians use to distinguish between in situ and invasive carcinoma. Beneath the basement membrane lies the underlying connective tissue, which provides structural support and houses the blood vessels responsible for nourishing the avascular epithelium above. And in the middle of all this are the epithelial cells themselves, the primary structural units, tightly packed together, connected by specialized junctions, including tight junctions, desmosomes, and gap junctions, which collectively maintain tissue integrity and control intercellular communication.
Before we can name and categorize different types of simple epithelium, we need to understand the classification system itself, and it operates in 3 dimensions. The first dimension, the y-axis, tells us about layers. How many layers of cells are present? If there is only one single layer of cells, all resting directly on the basement membrane, that is simple epithelium. If there are multiple cell layers, that is stratified epithelium. This is the most important distinction for today's video. The second dimension, the x-axis, describes cell shape. Epithelial cells come in three fundamental shapes. Squamous cells are flat and scale-like. Cuboidal cells are approximately equal in height and width, like a cube. Columnar cells are taller than they are wide, like a column. The third dimension, the z-axis, describes specialized surface modifications or functional adaptations, such as cilia on the apical surface, microvilli forming a brush border, or the process of keratinization in surface skin cells. Today's focus is simple epithelium, exactly one single layer of cells, all resting directly on the basement membrane. Every single nucleus you see in a section of simple epithelium should be at approximately the same height. There are four major types of simple epithelium: simple squamous, simple cuboidal, simple columnar, and pseudostratified columnar. We will now examine each one in detail.
The first and most fundamental type is simple squamous epithelium, and its design philosophy is extremely minimalism. These cells are extraordinarily thin and flat, like floor tiles or fish scales pressed against each other. When you look at one from the side, the cell body is barely thicker than the nucleus itself, which bulges upward at the center like a speed bump. The classic fried egg appearance under a light microscope. Why so thin? Because simple squamous epithelium is the body's high-speed exchange surface. Its minimal thickness means that molecules, oxygen, carbon dioxide, nutrients, waste products, can cross from one side to the other almost instantaneously by simple diffusion. There is no metabolically expensive active transport machinery needed here. The thinness of the cell is the function. You will find simple squamous epithelium in two critical anatomical locations. First, in the alveoli of the lungs and the walls of capillaries, where millisecond gas exchange between air and blood is essential for every breath you take. Second, in Bowman's capsule and the glomerulus of the kidney, where it forms part of the filtration barrier that processes approximately 180 liters of plasma per day. An important exam fact: simple squamous epithelium is the most fragile type. It offers minimal mechanical protection, which is precisely why it is never found in areas subjected to physical wear. Its sole purpose is rapid, passive diffusion.
Simple squamous epithelium is so widespread in the body that histologists have given it two distinct special names, depending on exactly where it is located. When simple squamous cells line the internal surfaces of fluid-filled body cavities, such as the pleural cavity surrounding the lungs, the peritoneal cavity lining the abdominal organs, and the pericardial cavity surrounding the heart, the tissue is called mesothelium. Mesothelial cells not only form a smooth, frictionless surface that allows organs to glide against each other without tearing, but they also secrete a thin film of serous fluid that acts as a biological lubricant. Clinical relevance: malignant mesothelioma, an aggressive cancer strongly associated with asbestos exposure, arises directly from these mesothelial cells. When simple squamous cells line the interior of blood vessels and lymphatic vessels, the tissue is called endothelium. Every single blood vessel in your body, arteries, veins, and capillaries, is lined by a single layer of endothelial cells. These are not passive pipes. They are metabolically active gatekeepers that regulate vascular tone, control the passage of white blood cells into tissues, prevent inappropriate blood clotting, and respond dynamically to local chemical signals. Endothelial dysfunction is a key early event in atherosclerosis, the disease process underlying most heart attacks and strokes. So, to summarize, same cell type, same shape, but the location transforms the name and the specific clinical significance.
Moving up in complexity, we now encounter simple cuboidal epithelium, and the change in cell shape signals a dramatic change in function.
These cells are distinctly taller and more voluminous than squamous cells, appearing roughly cube-shaped with equal height and width. Their nuclei are large, perfectly rounded, and centrally located. When you look at a cross-section under the microscope, the nucleus looks like a clean, dark sphere sitting in the exact center of the cell. This large, prominent nucleus is a visual clue that these cells are metabolically very active. And that is exactly the point. The increased cellular volume of cuboidal cells provides the internal machinery necessary for metabolically demanding work: secretory function, excretory function, and absorptive function. These cells are essentially miniature chemical factories. Simple cuboidal epithelium lines the small ducts of glands, including the salivary glands, such as the parotid gland, where it forms the duct walls that transport saliva to the oral cavity. Critically, it also lines the proximal and distal convoluted tubules of the nephron in the kidney, the sites of enormous active reabsorption and secretion as the kidney processes filtered blood. Additionally, simple cuboidal epithelium lines the thyroid follicles, where specialized cuboidal cells called follicular cells synthesize and secrete thyroid hormones T3 and T4. Remember, if you see a small round duct or tubule lined by a single layer of cube-like cells with central rounded nuclei, that is simple cuboidal epithelium.
Now we arrive at simple columnar epithelium, the tall, sturdy, pillar-like cells designed for durability and high-volume work. The defining visual feature is immediately clear. Height is significantly greater than width. These cells look like tall rectangles or pillars standing side by side. Unlike the central nuclei of cuboidal cells, the nuclei of columnar cells are oval in shape and consistently positioned close to the basal lamina, near the bottom of the cell. This basal nucleus placement is a key diagnostic feature and reflects the organization of the cell's internal machinery. The robust physical depth of simple columnar cells allows them to withstand considerable physical wear and tear, the constant churning, acid exposure, and friction of high-activity body surfaces. This is why simple columnar epithelium is the lining of the entire gastrointestinal tract, from the stomach to the rectum, as well as the cervix of the uterus. A critical specialization of simple columnar epithelium is the presence of goblet cells, specialized mucin-secreting cells scattered between the columnar cells like pale pink wine goblets. These goblet cells synthesize and release mucin, which mixes with water to form mucus, a protective gel coat that lubricates the gut lining, facilitates food movement, and shields against digestive enzymes and stomach acid. In addition, many simple columnar cells of the small intestine develop a specialized apical modification called a brush border, densely packed microvilli that massively amplify the surface area available for nutrient absorption, increasing it by up to 20-fold.
Here is where things get genuinely fascinating, and where many students are initially tricked. Pseudostratified columnar epithelium appears at first glance to be stratified, to have multiple layers of cells. Look at it under the microscope and you will see nuclei at different vertical heights throughout the tissue, seemingly suggesting a multi-layered arrangement. But this is a biological illusion. Pseudo literally means false. Here is the reality. Trace the cell walls carefully and you will find that every single cell makes direct contact with the basement membrane below. Every cell. There is only one true layer of cells, which is why this tissue is technically classified as simple epithelium. The apparent stratification is caused entirely by the fact that individual cells have different heights and widths, causing their nuclei to sit at different vertical positions within the tissue section. Think of it like a crowd of people of very different heights all standing in a single line. From above, it might look like 2 or 3 rows, but it is still just one line. Pseudostratified columnar epithelium has 2 defining functional specializations. First, its cells are ciliated. Their apical surfaces are densely covered with cilia. Second, goblet cells are interspersed throughout, continuously secreting mucin. Together, these create the mucociliary escalator, the body's primary airway defense system.
The mucus traps inhaled particles and pathogens, and the cilia beat rhythmically to sweep the mucus blanket toward the throat for swallowing or expulsion. This tissue lines the trachea, bronchi, and the male urethra.
Let's take a deeper look at the extraordinary functional machinery of pseudostratified columnar epithelium, because the mucociliary escalator is one of the most clinically important mechanisms in respiratory medicine. The system works in two perfectly coordinated stages. First, production. Goblet cells, scattered among the ciliated columnar cells, synthesize large quantities of mucin, a heavily glycosylated protein that, when secreted into the airway lumen, absorbs water and expands into a thick, sticky mucus gel. This mucus blanket sits on top of the cilia like a moving carpet and acts as a physical and chemical trap for anything inhaled: dust particles, bacteria, viruses, allergens, and pollutants. Second, propulsion. The cilia on the apical surface of the ciliated cells beat in coordinated, rhythmic waves, approximately 10 to 15 times per second, always in the direction toward the throat. This rhythmic beating propels the mucus blanket continuously upward and outward, clearing the airway around the clock, even while you sleep. The clinical relevance of this system is immense. In primary ciliary dyskinesia, a rare genetic disorder, the cilia are structurally defective and cannot beat effectively, leading to chronic respiratory infections, bronchiectasis, and classically, situs inversus. In cystic fibrosis, a mutation in the CFTR gene disrupts chloride and water transport, producing abnormally thick, sticky mucus that clogs the airways, impairs mucociliary clearance, and creates ideal conditions for chronic bacterial colonization, particularly by Pseudomonas aeruginosa. In smokers, chronic toxin exposure paralyzes the cilia and kills goblet cells, destroying mucociliary clearance and triggering the characteristic smoker's cough as a mechanical compensation.
Let's now step back and synthesize everything we have learned with the big picture comparative overview, because in your practical exam, you will need to identify these tissues rapidly from a microscope image alone. Here is your diagnostic toolkit. Simple squamous, look for extremely flat, tile-like cells with a central bulging nucleus, almost invisible in cross-section. Function: rapid gas and nutrient exchange. Classic locations: alveoli, capillaries, Bowman's capsule, body cavity linings. Simple cuboidal, look for cube-shaped cells, equal in height and width, with central and perfectly rounded nuclei. Function: secretion and absorption. Classic locations: nephron tubules, salivary gland ducts, thyroid follicles. Simple columnar, look for tall, rectangular cells, taller than they are wide, with oval nuclei pushed down toward the base. May contain pale goblet cells. Function: wear resistance, secretion, and absorption. Classic locations: digestive tract and cervix. Pseudostratified columnar looks stratified but is not. All cells touch the basement membrane and nuclei appear at variable heights. Ciliated apical surface. Contains goblet cells. Function: mucus secretion and propulsion via mucociliary escalator. Classic locations: trachea, bronchi, male urethra. Master these 4 patterns and you will be able to identify any simple epithelium on sight. The underlying logic is always the same. Shape equals function. The thinner the cell, the faster the exchange. The taller and more metabolically loaded the cell, the more secretory and absorptive work it performs.
We close with one of the most instructive and clinically important examples of what happens when epithelium goes wrong, a process called metaplasia, and specifically the condition known as Barrett's esophagus. In its normal state, the esophagus is lined by stratified squamous epithelium, a multi-layered, tough, highly protective tissue designed to handle the mechanical stress of swallowing solid food. Under normal conditions, this lining is well suited to its task. Now, introduce a chronic stressor, gastroesophageal reflux disease, or GERD, the repeated backwash of acidic stomach contents into the lower esophagus. Over time, this chronic acid exposure is simply too much for the stratified squamous lining to handle. In response, the body initiates a process called metaplasia. It defensively replaces the normal epithelium with a new cell type that is better equipped to tolerate an acidic, gastrointestinal-like environment. The result is Barrett's esophagus. The stratified squamous lining is replaced by non-ciliated simple columnar epithelium, often with intestinal-type goblet cells, a tissue type more typical of the intestinal lining. This change can be seen on endoscopy as a characteristic salmon pink discoloration in the lower esophagus. Why is this critical? Because Barrett's esophagus is a pre-malignant condition. The metaplastic columnar cells carry a significantly elevated risk of undergoing further transformation, dysplasia, and ultimately esophageal adenocarcinoma, one of the fastest rising cancers in the Western world. This is why patients with Barrett's are enrolled in regular endoscopic surveillance programs. This is what histology makes real. Understanding cell types is not just academic, it directly explains disease, risk, and clinical management.